Hello, everyone, and welcome to today's webinar, Next Generation Flow Cytometry Solutions for Earlier Detection of Primary Immunodeficiency, Impact of Late Diagnosis in Adult Patients. I am Sydney Panilla of LabRoots, and I will be your moderator for today's event. Today's web seminar is presented by LabRoots and brought to you by BD Biosciences. To learn more, please visit bdbiosciences.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble hearing or seeing the presentation. I would now like to welcome our speakers for today's webinar, Dr. Fernando Solano Ramos, Head of the Haematology Department, General Hospital, Nuestra, Señora del Prado, Talavera de la Reina, and Dr. Nahir Moreno, Hematologist, General Hospital, Nuestra, Señora del Prado, Talavera de la Reina. Dr. Moreno, you may now begin your presentation.
Everybody, I am Nahir Moreno, hematologist from the Hospital Nuestra Señora del Prado in Talavera de la Reina, Spain. Today, Fernando Solano, who is the head of the Department of Haematology, and we are glad to talk about next generation flow for earlier detection of primary immunodeficiency and the impact of late diagnosis in adult patients. These are our disclaimers. First, I want to tell you about us. Castilla-La Mancha is an extensive region that represents 15% of the Spain's national territory and 4% of its population, with around 2 million people living in 80,000 square kilometers. In our department, in Talavera de la Reina, 15 years experience in flow cytometry, focused mainly on hematological diagnosis. At present, we are 2 physicians and 7 laboratory technicians. We process hematological samples from our own hospital, but since 2011, we provide service to several hospitals in the region for hematological diagnosis by flow cytometry, and more recently, in the study of immunodeficiencies. We are currently processing more than 1,400 samples each year. But what's happening with primary immunodeficiencies in Castilla-La Mancha? In Spain, the prevalence of primary immunodeficiencies is 1 case per 10,000 people. The Spanish registry for primary immunodeficiencies includes 2,050 registered cases. Although Castilla-La Mancha covers a large territory, its contribution is minimal, only 0.1% of cases. This gap may be due to patients are received with reduced clinical and laboratory evaluation. There's no specific immunodeficiency unit in our region, cumbersome transfer of patients to another region for specialized care, and patient clinical information not easily accessed between hospitals. That's why it is important to know more about primary immunodeficiencies. So, they are a group of congenital and often hereditary diseases characterized by quantitative and qualitative alterations of the elements of the immune response, leading to complications such as increased risk infections, including bacterial, viral, and opportunistic infections, autoimmunity and immune dysregulation like cytopenia, autoimmune diseases, allergic phenomena, atopic skin, and malabsorption. And malignancy, mainly lymphoproliferative syndromes, but also solid tumors. So, primary immunodeficiencies encompass nearly 500 inherited disorders, most of them due to single gene mutations that result in impaired immune development and function. And it can be classified as you can see in the screen, immune deficiencies affecting cellular and humoral immunity, combined immunodeficiencies with associated or syndromic features, predominantly antibody deficiencies, diseases of immune dysregulation, congenital defects of phagocyte number, function, or both, defects in intrinsic and innate immunity, autoinflammatory disorders, complement deficiencies, bone marrow failure, phenocopies of error of immunity. The severity of primary immunodeficiencies may rank from life-threatening disorders presented in infancy to less severe disorders diagnosed in adulthood. Because of this, adults' diagnosis is difficult and often takes many years. Adult patients usually have many medical visits because of infections that can require admission or not, allergies, autoimmunity problems, etc. They take multiple treatments throughout their life, but they are still not well. Until one day, 9 to 15 years later, the doctor, looking at their medical and family history, finally suspected and asked for more target studies, like a basic study with blood count, autoimmunity profile, serologies, protein analysis, immunoglobulins, and a more direct study like flow cytometry, functional studies, and genetic study. As we can see, there are challenges in diagnosis because it is often delayed due to healthcare system deficiencies, because lack of awareness. Primary immunodeficiencies are often perceived by adult care physicians as rare congenital conditions. Misattribution of symptoms like bronchitis, sinusitis, pneumonia are often misattributed to infections rather to immune status. Not only recurrent or relevant infections, because primary immunodeficiencies are frequently associated with non-infection manifestations, such as autoimmunity, malabsorption syndromes, allergic conditions, and an increased risk of malignancies. Several specialists involved in the symptom phase because their multi-system involvement in primary immunodeficiencies are often managed by multiple specialists, frequently in an uncoordinated manner. As we can see, there are challenges in diagnosis because it is often delayed due to healthcare system deficiencies. Because lack of awareness, primary immune deficiencies are often perceived by adult care physicians as a rare congenital conditions. Misattribution of symptoms, such as bronchitis, sinusitis, pneumonia, are often misattributed to infections rather to immune status. Not only recurrent or relevant infections, because primary immune deficiencies are frequently associated with non-infection manifestations, such as autoimmunity, malabsorption syndromes, allergic conditions, and an increased risk of malignancies, which may precede or coexist with recurrent infections. Several specialists involved in the symptom phase. Due to their multi-system involvement, primary immune deficiencies are often managed by multiple specialists, frequently in an uncoordinated manner. There is a late onset of primary immune deficiencies that may arise due to specific genetic variants with incomplete penetrance, age-related immune senescence, somatic mutations affecting immune regulation, or epigenetic dysregulation leading to progressive immune dysfunction. This delay causes an impact in a negative way, increasing the risk of severe infections because without timely diagnosis and treatment, individuals with primary immunodeficiency are more susceptible to frequent, severe, and potentially life-threatening infections. Complications, because delayed diagnosis can lead to complications such as chronic lung disease, organ damage, and autoimmune disorders, leading reduced quality of life, higher healthcare cost, psychological impact, and leading to poor outcomes. In this context, we have the challenge of diagnosing adult patients and differentiate late onset primary immunodeficiencies from secondary immunodeficiencies. So here you can see several articles that offer certain clues that can help us to differentiate these two entities, considering characteristics like etiology, age of onset, identifications of triggers, family history, T and B cell function, immunoglobulin levels, etc. Here we have the age distribution of primary immunodeficiency categories. As you can see, antibody and complement deficiency are the most diagnosed in adulthood. Furthermore, other categories have an important group diagnosed in adulthood too. There is an interesting article of Silvia Sanchez Ramon and Maria Palacios that can help us to identify primary immunodeficiency in adults, especially in the context of hematological patients. In this ambidextrous cohort study, they propose the hypothesis that there exists a hidden subgroup of primary immunodeficiency among those classified as having a secondary immunodeficiency. Such patients could potentially benefit from tailored follow-up strategies and specific treatments. So they chose 151 secondary immunodeficiency patients based on the criteria outlined in the latest clinical guidelines, which include recurrent or severe infections, a reduction in serum immunoglobulins by at least 2 standard deviation below the normal mean, and failure to mount an antibody response in the presence of diagnosed malignancy. This group was compared with 17 patients diagnosed of common variable immunodeficiency. They studied 37 clinical and laboratory variables and reclassified a group of patients as suspected primary immunodeficiency group when having recurrent or severe infections prior to lymphoma and hypogammaglobulinemia. The analysis highlighted significant distinctions, particularly in the rates of recurrent and severe respiratory infections during childhood, and the presence of family history of lymphoid malignancies. Among the analytical assessment, significant differences were noted in levels of free light chain in serum in both kappa and lambda, as well as in the sum kappa plus lambda, with all values significantly lower in the suspected primary immunodeficiency group than in the secondary immunodeficiency group. This finding aligns with prior research identifying the sum kappa plus lambda as a critical biomarker for common variable immunodeficiency diagnosis. Considering only the significant variables obtained, they used machine learning for the development of a tree-decision model that could aid in the task of discriminating between suspected primary immunodeficiency group and secondary immunodeficiency group, with high sensitivity, specificity, and accuracy for primary immunodeficiency prediction. Thus, patients with free light chain sum less than 21 can be directly reclassified as primary immunodeficiency. When the sum is more than 21, the algorithm considers the history of recurrent or severe infection in childhood. So the patient is classified as a primary immunodeficiency when there is a history of infections. Finally, genetic screening in 59 patients of suspected primary immunodeficiency group revealed that 66%, that means 39 patients, presented at least one genetic variant related to inborn error of immunity, supporting the findings of the study. Now, Fernando Solano is going to talk about the role of flow cytometry in the study of primary immunodeficiencies and or experience.
Thank you, Nahir, for your presentation. We will now pass it over to Fernando to begin his portion of the presentation. Fernando, take it away.
Hello, I'm Fernando Solano, a colleague of Nahir Moreno. I just tell you what about the next generation flow cytometry? What is that? Next generation flow is a multiparametric flow cytometry approach developed by the Euroflow consortium. It is based on highly standardized protocols for sample preparation, data acquisition, and analysis of hematologic and immunodeficiency specimens. This methodology aims to enhance the sensitivity, the specificity, and accuracy of diagnosis, prognosis, and therapeutic monitoring in this clinical context. This technology is rapid, ultrasensitive, and standardized from start to finish. It employs pre-configured and clinical meaningful panels of 8 or more colors ready to use. Its full standardization enables interlaboratory comparability of samples. As a limitation, samples must be fresh. The methodology requires substantial technical training, and high numbers of cells must be acquired to meet the required sensitivity standards. Through this technology, we can identify and assess defects in one or more compartments of the immune system. This enables us to guide patients toward an accurate genetic diagnosis and provide valuable information in case where a definitive genetic diagnosis is not yet available. To share with you our experience, we have analyzed 76 samples that we received during the first 6 months in 2024. Nearly half of them could have a suspicion of primary immunodeficiency, and as you can see, the range of age is quite wide, with a median of 38 years. Most of them were adults, as you can see. The clinical information accompanying each sample was not only related to hypogammaglobulinemia or recurrent infections, but also to autoimmune disorders, allergies, or cancer. When we analyzed our samples with NGF technology, we found that most of the cases had low levels of absolute numbers in more than one compartment of immune cells, and extremely low levels in some cases as well. To share with you, now we share with you some examples of real life, like the patient number 1, that is a 20 years old female. She had intrinsic asthma since she was 12, and several episodes of pneumonia. One of them required ICU hospitalization. There was no autoimmune conditions or thrombosis in his clinical report, and the patient hadn't received any steroid or immunosuppressive drugs. As you can see, the level of 3 in all immunoglobulins were under normal values. And after analyzing the sample with our platform PyroTube, we found the absolute numbers of pregerminal and postgerminal B cell compartments were under normal values. We also found low levels of absolute numbers of CD4 and CD8 lymphocytes. So then, we suspect a non-severe combined immunodeficiency case. What do we do at that moment? With our report, the patient was sent to a specialized unit for final assessment, and final diagnosis agreed with our phenotypic suspicion, which in the end has led the patient to be treated with immunoglobulins, and she hadn't any longer episode of pneumonia. The patient number 2 is a 20 years old female that had recurrent otitis since she was a child. She had not received any previous steroid of immunosuppressive treatment. In 2016, the patient was diagnosed of follicular lymphoma, and normal immunoglobulin levels were found at this moment. As you can see in the left-hand side image, FDG uptake was low as expected in a follicular lymphoma. Treatment with R-bendamustine was initiated in 2016 and followed with rituximab maintenance until 2019. Although the patient is in complete remission since then, during the follow-up, we detect that the level of serum immunoglobulins remained very low 4 years later. So, exploring this case with NGF, as you can see in this plot, we found very few post-germinal center switch and unswitched memory B cells. Other immune subsets had normal values. As the first patient, this female was sent to for confirmatory study in Clínico San Carlos Hospital in Madrid. Final diagnosis achieved by additional tests agreed with our suspicion, and she started immediately treatment with intravenous immunoglobulins. She has no longer an episode of the otitis or pneumonia so far today. The patient number 3 is a 30 years old male with previous medical history of Hodgkin disease diagnosed when he was a child. Treatment with a pediatric protocol was initiated and patient remains in complete remission so far today. The patient has shown normal immunoglobulins level during all the tests conducted so far. In 2017, the patient was diagnosed with refractory ITP, unresponsive to treatment with steroids, immunoglobulins, and thrombopoietin receptor agonists, which made it necessary to perform a splenectomy. Since 2010, the patient has experienced erratic growth of laterocervical, supraclavicular, and axillary lymphadenopathies without a clear constitutional syndrome or significant laboratory abnormalities. A PET scan was performed revealing lymphadenopathies with high FDG uptake in both sides of the diaphragm. However, all 3 lymph node biopsies reveal benign lymphoid follicular hyperplasia. None of them showed evidence of lymphoma. As you can see, the biopsy samples show preserved lymph node architecture with lymphoid follicles visible on hematoxylin and eosin staining, as well as normal follicular center evidence by high expression of CD10 and Ki67. The immunophenotypic analysis of the lymph node biopsies by flow cytometry did not reveal clonality in any of the B or T cell subpopulations. But analyzing several blood samples of the patient during the follow-up, we found systematically low levels of naive CD4 T cells. Using NGS, we identified a single variant associated with lymphoma, such as Notch1, but 7 different pathogenic variants related to primary immunodeficiency were found. This case is still under investigation to confirm or rule out the presence of primary immunodeficiency. The patient was sent to clinical study in Clínico San Carlos Hospital in Madrid, and genetic, phenotypic, and functional studies are ongoing so far today. As take-home messages, you have to know that there is an important group of primary immunodeficiency diagnosed in adulthood. Most of them have symptoms of the recurrent or relevant infections like autoimmunity, cytopenia, allergies, and cancer. And the diagnosis is often delayed due to a lack of awareness. And this delay concerns survival, quality of life of immunodeficiency patients, but also increasing healthcare costs. So what is important, an early diagnosis in this patient? An early diagnosis of this patient can improve immunoglobulin replacement and proper antibiotic strategy and vaccination, and flow cytometry can help in the orientation of this condition to improve their management. We want to thank our colleagues in immunology group of University of Salamanca, with Nacho Criado and Dr. Nacho Criado and Dr. Julia Almeida, and our colleagues of Immunology Department in Clínico San Carlos, like Silvia Sanchez Ramon, our Beckton Dickinson technical support, and our team of laboratory technicians, of course, of our patients. So thank you for your attention.
All right, wonderful. Thank you both very much for your very informative presentations. We will now go ahead and move into the live Q&A portion of the webinar. So if you happen to have a question that you would like to ask, please do so now. Just type your question into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for. Okay, let's go ahead and get started here. The first question that we have says, what are the indications for evaluating primary immunodeficiencies using flow cytometry?
If you want Nahir to answer, whatever you want.
Okay. The indications for the study of primary immunodeficiency by flow cytometry are mainly patients with recurrent or severe infections, mainly with unknown case. It could be patients with bacterial, viral, or fungal infections, and this characteristic it can be seen in patients in childhood, but also in adulthood patients. So it is important to take it in account. Another indication is patients with cytopenia, especially in patients with autoimmune or patients with unexplained cytopenia, like anemia, autoimmune anemia, thrombocytopenia, but also autoimmune neutropenia. Of course, patients with autoimmune diseases, patients with syndromic features, and of course, patients with adenopathies, splenomegaly, unexplained. You want to add something else, Fernando?
I like to say that in daily basis we have some patients treated or assessed by rheumatologists, allergologists, and these specialists have to keep in mind that probably they have some immunodeficiency, primary immunodeficiency patient, and they have to be aware to explore innate and acquired immunodeficiency in a proper way to orient it to by orienting or assessed probably primary immunodeficiency that we have hidden in our clinical daily base.
All right, fantastic.
Okay.
Thank you both so much. The next question that we have here says, what is the difference between PID screening by flow cytometry and the conventional diagnostic approach, and what are the advantages?
Okay. The conventional screening for primary immunodeficiency is mainly based on clinical features, personal and family history, and quite basic laboratory tests such as complete blood count, immunoglobulin levels, and complement measurement. Incorporating data from next generation flow, multiparametric flow cytometry, can provide us with an extensive information of absolute counts of all compartments, not only acquired immune cell compartment, be memory B cells, switch and unswitch, or T cells, but also monocytes, CD16 monocytes, neutrophils, eosinophils, and dendritic cells. And this technology can help us to detect early or better guide the diagnosis of primary immunodeficiency cases in adult patients.
Yeah,
I think there is a great difference approach of our immunodeficiency suspicions of the patient. Sorry.
I think genetic study is expensive and it's not always available. In addition, many primary immunodeficiencies has not a genetic basis identified. In this context, flow cytometry can offer a rapid, cheaper, and a useful alternative to identify patients with primary immunodeficiency. I think it's a very good option to implement in the study of these patients.
Okay, wonderful. Thank you both very much. We are getting some really great questions that are coming in here. So the next one that we have says, thank you so much for the interesting and informative talk. Question is, do you think the IEI was the reason why these patients developed lymphomas and other serious life-threatening diseases? And if so, what could have been done earlier in their lives to diagnose them early on and avoid such complications?
Immunodeficient patients have tenfold probabilities to developing lymphoma. We have to be aware of these possibilities, and we have to investigate the patient more often than we think previously. I think it's very important to keep this in mind, because early detection of lymphoma in this patient could save the life of these patients and improve the quality of life and reduce public or private health costs.
Yeah, in the article we mentioned in the presentation, they mentioned that patients with lymphoma identified as primary immunodeficiency got the benefit in a tailored treatment when they had the lymphoma. I remember that they used a prolonged use of rituximab, and they used a little bit different schedule of the treatment of chemotherapy. So they get a benefit. Yeah.
Great, thank you. The next one that we have here says, is this technology at the research stage or is it being used in the hospital regularly? If a normal person would like to do a screening, what is the cost?
This technologies is not a research stage. Is CE in vitro diagnose certificate. It has a in vitro diagnose certificate, and is in Europe it is used as in a daily basis in immunodeficiency units and in several hospitals, and we can make these studies in a daily basis. It's not a research study. It's a very good platform of multiparametric approach of immune cell compartments, not only acquired but also innate immune cell compartments. It provides us with a lot of information, and not only diagnosis but prognosis and monitoring treatment, and prevent infections in these patients.
Yes, we use it in the daily practice with our hematological patients, but also for patients to other services. The cost, well, I think is not expensive. I think it's similar to other flow cytometry studies.
Okay, fantastic. We do have a few more here. This next one says, are the normal values for all immune cell subpopulations using PIDs available published? How many healthy individuals were included in this analysis?
Yes, the answer is yes. Normal values of healthy donors, not only donors, but also in all ranges of age, from newborn to more than 70 years old, and it is published in a GACI journal. This is a presentation. This is a work published by Elena Blanco and Ignacio Criado, two of our colleagues in Salamanca Immunology Group. I don't know what is the real number of healthy controls included in the platform, but I think a minimal 20 cases of each range of age, from 10 to 10 years, using newborn blood samples from 1 year to 10 to 20, and so on. But I don't know what is the real number. Not minimal. I think 10 or 20 subjects of each range of age?
Yeah, we use the pilot tube, and we analyze the sample with the software of analysis Infinisight. And when you use the automatized analysis, you get the range, the normal levels for a range of age.
Perfect. Thank you both very much. The next one that we have here says, I believe it's supposed to say, is there some kind of certification for laboratories that perform PID diagnosis?
Yes, we have ISO certification of our lab, cytometry lab, and I think we have to the PIDOT2 platform, and using PIDOT2 means that you have to accomplish the requirement of Euroflow procedures and Euroflow. I don't know how to say in English. You have to have your cytometer in a proper way of compensation, and you have to accomplish all procedure requirements of Euroflow, because it's completely necessary to compare your results with normal health donors, and in the platform, and with your colleagues in another laboratories is crucial to be in order.
Okay, fantastic. We do have a couple of more here. This next one says, good evening. I am an internal medicine doctor studying humoral PIDs in a small center in Italy, and I am not an expert in flow cytometry. Our flow cytometry system is based on PDOT, but I would be interested in identifying CD21 low B cells also in COVID patients. We cannot afford to buy a different tube. Can you give me some more suggestions?
I think it's CVID patients, no, not COVID patients.
Yes.
Sorry about that. Sorry, CVID. You are absolutely right. I read that a little bit too fast. CVID.
Okay. It's a very good question, and we don't have either CD21 in, but we have a 12 colors, 12 colors cytometer, and we are thinking of improving to put CD21 in PIDOT tube to make a better diagnosis, but it's quite difficult. Probably we have to make another tube, but in-house tube, not certificate. But I think PIDOT tube is quite sufficient, quite good platform to assess or orient immunodeficiency patients. Probably it would be better to add CD21 in these cases, but we don't know either. We don't have it either.
Yes, as Fernando said, we neither have the CD21, but with the pilot tube, you can You can see the post-germinal center B cells, and you can identify the switch B cells. And I think with that information and the clinical information, immunoglobulin levels information, you can do a very good approach about the diagnosis of common variable immunodeficiency.
Perfect. Thank you. The next one that we have here says, is it possible to distinguish PID like GATA2 deficiency from aplastic anemia?
Using Python 2, of course, not, I think, because GATA2 is immunodeficiency that we have to explore or investigate the myelodysplasia. Python 2 can not, I think, is not good to use that to distinguish GATA2 from aplastic anemia. You have to perform bone marrow biopsy, and you have to. Recently, we have a patient with GATA2, and this patient is. We have to perform each year bone marrow biopsy because she has a very probability, a quite big probability of developing myelodysplasia or acute leukemia.
Yes, I think it is important to take in account that the syndrome it has a genetic basis. So for have to make the genetic study, but with the pilot tube you can get some features of the subpopulations that can help to make the approach in this kind of syndromes. You can find a list of alterations of these subpopulations, and you only can get this approach, but it's not the definitory technique by diagnosis.
Okay, great. The next one we have here says, is it important to distinguish the normal ranges of the different cell subpopulations studied according to the patient's age?
Yes, we think it's very important because there is a lot of variability of according to the patient age. And there is, for example, children with, for example, 5 or 6 years old have more naive B-cell, pregerminal B-cell compartment, and less memory B-cell, memory switch and unswitch B-cell compartment. There is a quite range of normality, and we have to make the distinction according to patient age. Is crucial for us.
Gary.
Okay, wonderful. We have had a really great influx of questions come in. We still have a few more, so we are going to go ahead and continue. The next one that we have here says, how does flow cytometry complement genetic testing? Should we always use it?
I think flow cytometry, next generation flow cytometry based on multiparametric analysis and use of platforms comparing your sample with a normal range of reference samples of healthy controls is very important, and we think we have to make an orientation using cytometry before use genetics testing because flow cytometry is more rapid than genetic testing, and you can orient your genetic studies according to the data of cytometry.
Yes, as I already said, you can't do the genetic study to all patients because it is expensive, and not all primary immunodeficiency has a genetic basis. So with the study by flow cytometry, you can do the screening, and you can get a better group of patients who can then get a benefit of the doing the genetic study.
Perfect. The next one that we have here says, what is the typical patient profile you receive at your center?
We have several types of patients with a diagnostic orientation toward primary immunodeficiency. Some are children who not only suffer from recurrent or relevant infections, but also autoimmunity, cytopenia, as we said before, and often allergic problems. At other times, we see other patients who were previously assessed by other specialties like rheumatology, allergology, or gastroenterology, for example, is very common in primary immunodeficiency, late onset primary immunodeficiency. A patient could have malabsorption. In most cases, there is a story of previously recurring infections during childhood or lymphoproliferative disorders, benign lymphoproliferative disorders, as you have seen in the examples. These are our profiles of patients that we received their samples.
Yes, many of our samples provide our own service for hematological patients, but it's true we have many samples from services of pneumology, pediatric service, internal medicine, with this features that Fernando mentioned.
Perfect. Okay, it looks like we have time for one final question here, so we will go ahead and wrap up with this one. It says, what is the protocol in your hospital for sending samples and receiving the report?
Nahir, if you want to answer the last question.
Okay. Well, we receive the samples of this type of patients. Usually we use the one tube of sample, and we process in our flow cytometry machine, the Lyric 2. We use the pilot tube, and after the processing of the sample, we analyze the sample in the Infinisite oh, I
Informatic application, for example.
yeah, informatical application, and we use the range 8 reference, and we made an inform that we send or upload in our informatical application in the healthcare system.
Okay, beautiful. Thank you again, Dr. Solano Ramos and Dr. Moreno, for your time today and for your very important research. We would also like to thank LabRoots and our sponsor, BD Biosciences, for underwriting today's educational webcast. Before we go, I would like to thank the audience for joining today and for their very interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by the speakers via the contact information you provided at the time of registration. This webinar can be viewed on demand. LabRoots will alert you when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, everybody, goodbye.
Bye.
Bye.
Thank you. Thank you, you all.